Welcome to my podcast, Diet, Disease, and Doctor Dialogues. In this episode, you can listen to an interview with an ER doctor to learn more about how blood pressure is controlled in the body, management of a patient with high blood pressure management advice for patients after an emergency visit, common side effects of antihypertensive medication, treatment of hypertensive emergencies versus urgencies, and what the healthcare system can do to better manage hypertensive patients and prevent emergency visits. Stay tuned for the next 15 minutes to learn about the ins and outs of hypertension.
I'm here with Dr. Lozano, emergency care physician, to discuss hypertension in an emergency setting. Would you like to say a little bit about you?
Yes, I'm an emergency medicine physician. I've been practicing emergency medicine for about 30 years. I'm also board certified in internal medicine and occupational medicine. And currently, I am working in telemedicine in addition.
All right, thank you for coming on my podcast. I really appreciate
Sure.
it. And let's get to these questions. So, first one, how do you decide which class of antihypertensive medication to use in an emergency setting?
Well, I think you need to know a little bit about how blood pressure is controlled in the body. The blood pressure is controlled by and regulated by different organs in the body, including the brain, the heart and blood vessels, the kidneys, and the adrenal glands. Um, and so when internists or primary care physicians are trying to control the blood pressure, they use different types of medicines that uh, interfere with proteins and enzymes that can cause elevated blood pressure. Um, and that system in the kidneys that really regulates blood pressure is the renin-aldosterone uh, system. And what happens, for example, when your blood pressure drops, the kidney produces renin, which is an enzyme, a protein, and renin splits another protein called angiotensin, and it produces angiotensin. It splits it into angiotensin 1 and angiotensin 2. Angiotensin 2 basically is what causes the kidney to retain sodium. And when you retain sodium, you retain more water, which increases the volume of your blood vessels, which in turn increases the blood pressure. And angiotensin 2 also causes the adrenals to secrete a hormone called aldosterone. And aldosterone also works to increase your blood pressure. So when physicians use medications to lower your blood pressure, what they can use are medications that stop the conversion of angiotensin, which, as I just explained, causes increase in the blood pressure. So I don't know if that's too much information to know or to understand, but I think it gives you some kind of idea of how the blood pressure is regulated in the body and how complicated it is in terms of controlling blood pressure. And your question was,
How do you decide which class of antihypertensive medication to use in an emergency setting?
so in the emergency department, usually when people come in and they have elevated blood pressure, it's usually due to something else. And so we have to figure out if the primary problem is their blood pressure, or could it be that they're in pain, or meaning like chest pain, or maybe they have a laceration, they're anxious and upset, and the blood pressure is elevated. What we usually do is we repeat the blood pressure after we calm the patient down, depending on how high it is. And then if it continues to be elevated, and if the patient has a history of hypertension, what we usually do is we look at the category of medication that they're on, and perhaps we can give them an extra dose of their medication that they usually take on a regular basis. And that many times can control the blood pressure.
Do you think genetic testing could play a role in the ER for tailoring antihypertensive therapy, knowing that it's just such a complicated process, complicated disease?
Well, what I know about genetic testing and hypertension is that it's in the experimental phase right now, I believe.
Yeah.
Um, and you're talking about gene therapy, right? Is that what
Yes.
you're talking about? Gene
I was
therapy?
when I was researching, I found like these multi-gene panels
Hmm.
where they were testing the DNA for certain genetic determinants that, according to like the current literature, had an association with response to the different medications, and they found that the top recommended drug from the algorithm had a better blood pressure control for those who took the medication they were recommended by the algorithm rather than the ones that weren't recommended.
Okay. I'm not familiar with those studies, so
Mhm.
I really can't comment on that. But I think that gene therapy is probably the future of how to control um, blood pressure. The problem with controlling people's blood pressure is compliance. That many people can't remember to take the medicine on a daily basis or twice a day if that's how it's prescribed. And a lot of people think that once your blood pressure is controlled, you can stop the medicine because you don't have high blood pressure anymore. So the biggest issue is compliance.
On that topic, like what advice would you give to patients about managing their blood pressure, like after an emergency visit?
Well, what we usually do is we emphasize compliance to the patient. Um, and sometimes what we do, we usually don't change medications in the emergency department because the primary care physicians really don't like us to do that. But sometimes, in my case, I will tell the patient that there is a medication where you only have to take it once, and it has a very good record at controlling your blood pressure. And if you're taking a medication once a day, most people can remember it like taking a vitamin. So sometimes I give them suggestions to discuss with their primary care physician the next time they make an appointment. And usually, if we do see them and their blood pressure is elevated, we recommend that they have an appointment with their primary in 1 or 2 weeks after the emergency visit.
This is kind of switching gears a little bit. What are the most common side effects of antihypertensive medications you would see in the ER?
I would say the number one side effect is with diuretics, in my experience. The diuretics can cause abnormalities in your electrolytes, such as sodium and potassium, which may be dangerous. So, usually, when patients come in and they're on diuretics, we check their sodium and potassium to make sure that they are normal. I mean, if your potassium is low, you can have arrhythmias of the heart, and if your sodium is low, actually, if it's low and if it's very low, you can have seizures. So it's really important with anybody who's on an antihypertensive that is in the diuretic category to check their electrolytes. I would say that's number one.
Okay. And related to that, what are some of the biggest challenges you face when treating hypertensive emergencies?
Well, there are a couple of categories of hypertensive emergencies. One is a hypertensive urgency. The other is a hypertensive emergency. Hypertensive urgency is defined as a systolic blood pressure greater than or equal to 180 and or a diastolic blood pressure that is greater than or equal to 120. But what distinguishes the two types of categories is symptoms. Usually, with hypertensive urgency, the patient has no symptoms, or they might have like a mild headache. But with a hypertensive emergency, those patients can have end organ symptoms such as change in vision, change in mental status. They might have chest pain. On exam, they could have congestive heart failure, which would be fluid in the lungs. If you examine their eyes, they can have flame hemorrhages, or the optic nerve can look blurry when you look inside the eyes. In fact, a very high blood pressure can cause seizures. So there's a big difference between the two. And so it's very important for us as emergency doctors to do a complete exam on anybody that has blood pressures in that range. With a hypertensive urgency, we can treat them the same way that I mentioned before. We can either give them an extra dose of their regular medication, or we can use a faster acting medication that actually doesn't really lower the blood pressure too low, because if you do that, you actually can cause more problems with less perfusion of the organs. So one drug that we use is captopril, which actually is pretty fast acting. And you can give a low dose of that medication. Another is clonidine. And both of those two medications will lower the blood pressure pretty quickly, but not to very low levels. In terms of the other category, the hypertensive emergency case, those patients we can initially treat with clonidine or captopril to lower their blood pressure a bit. But most of those cases that have end organ damage or injury, we have to place them on intravenous medications such as beta blockers or alpha blockers. And those cases have to be admitted to the hospital, the hypertensive emergency cases. And our problem mainly in the emergency department is getting those patients that are hypertensive emergencies into the ICU, because usually the ICU is crowded, and it's really these patients that have hypertensive emergencies have to be watched very, very closely. And given that they're in the emergency department, it's really difficult for us to do that because we're dealing with heart attacks, strokes, and other patients who are gravely ill. So my main issue as an emergency doctor is to get the case into the ICU with the intensivist so that they can take care of the patient.
This leads me to wonder about how can the healthcare system improve to better manage hypertensive patients and prevent these emergencies?
Close follow-up of the patients. Given that hypertension in the majority of patients is asymptomatic, most people don't know that they have high blood pressure, so they don't really seek medical care. But what the primary care doctors need to do is to follow these patients very closely, not twice a year or once a year, but every few months, especially at the beginning when the high blood pressure was initially diagnosed. So that they should follow them very closely until the blood pressure is regulated, and then they can follow them perhaps every 2 or 3 times a year. And I always recommend that these patients have home blood pressure machines that they can calibrate, take them to their doctor's office, and to see how they differ with the blood pressure machines in the office, because those machines are calibrated on a daily basis in the clinic.
That's all I have for you. Thank you very much and for your in-depth explanations. Really appreciate it.
Okay, you're welcome.
That wraps up the first episode of Diet, Disease, and Doctor Dialogues. Thank you for tuning in with me today. In this interview episode, we looked into hypertension from the emergency room perspective. I hope this has given you ideas to better manage your blood pressure to prevent an emergency visit. But before I say goodbye, don't forget to subscribe. Your support means everything to me. So stay curious, stay safe. Until next time, this is Naomi Faleka, signing off from Diet, Disease, and Doctor Dialogues. See you soon!